Okay, good.
One of the things that I'm very excited about here is that not only are you guys going to have a new cancer center, how many jobs are going to be created?
The cancer center will open with close to 500 positions, and once it's fully open and operational, it'll be close to 1,000. I think there's probably 200 of those people working currently somewhere in Baptist Health, so the additional people will be new jobs. And of course, the spinoff effect of having this be a destination center, one, you don't, with the patients who are here now that are, like I said, are going to New York or Boston or Houston for treatment, they'll stay. So that has an impact. The patients who we bring in from around the world to have access to these therapies, these physicians, these research protocols, the proton therapy will have an additional impact that we do need to calculate, but it should be very significant.
And then the other question I have, because you are the COO, those of us in the insurance industry trying to represent our clients recently found out that Humana will no longer be part of your network. And there's a lot of clients that do live in the South that happen to have Humana. It becomes a real challenge for us, so just wanted to see what the workaround, if there is any, and how it impacts Medicare as well.
Well, I think the important thing to note, and we've sent out letters to you all individually, and certainly the patients. This was a unilateral decision on the part of Humana. We had a very long-standing relationship. Our contract was not due for actually even renegotiation at this point. And so they decided to take the step of terminating. We regret that that happened, and we did our best to avoid it. But again, the decision was in their hands, and so we moved forward. There are, of course, many, listen, we all know, look, what is the easiest thing in the world to sell? That is a very good product. We think we provide a very good product to the community. Humana's decided that they can proceed without this product. And then, so the patients and the companies and the individuals will make their own decisions about where they want to go. I'll do my best, and any one of these doctors that wants to jump up here, feel free. So, as I said, there's it is not a new technology, but certainly it is a very relatively unique technology. There are certain cancers that proton therapy is ideal for. So, for example, a number of pediatric cancers that can be treated in no other way. The proton therapy device is available for them. And we are partnering with Miami Children's Hospital to have them part of the proton therapy center, and we're looking certainly very much forward to that aspect of it. And that there are a number of specific other tumors that it's desirable for. Some of the treatments, for example, prostate, which have been very popular for prostate, and I think there's a lot of information that a number of ways of treating prostate cancer have similar outcomes. But the preference for proton is that there are very, very few patient side effects. So patients currently today from Miami travel to Jacksonville for prostate treatment by proton, and they have that treatment, and then they are out playing golf in the afternoon. So the ultimate outcome might not be different, but the patient's journey along the way to being able to fully function is quite different. And this is, to me, one of the things that we need to figure out. I was just talking to Frank a minute ago about this sort of thing. So if you have a patient who can immediately resume work and has minimal recovery, doesn't have to stay in the hospital, doesn't have to have home health care, can take care of his family, they don't need, all of the things that happen when you are recovering, if that's eliminated, that's a savings. And what we have to figure out is, how do we share that savings ultimately going forward? And I think with proton, you'll see that be adopted more and more and more with different different disease processes as time goes on. Do you have one other question? Or yes, sir. Yeah, of course. I'm not sure he even ate his regular lunch, so I'm not. So,
This was that written question that came to me. It was, what is, and I think it's a little bit lengthy, but what is Baptist doing to move from the high-cost provider to the lowest cost provider?
I'm certain to say to you that we are not aiming to be the lowest cost provider. We have very significant investments in, as you see, people, technology, programs. Do I think that there are ways for us to reduce costs and save money? Absolutely, I do think that is a fact. But we have aimed to provide a high level of service, to provide the best facilities, to provide the best physicians, to provide the most nurses on the floors for the patients. And as you can see, we have the highest level of patient preference and physician satisfaction and employee satisfaction for that matter, all of which we think translates into great outcomes, high levels of patient safety and quality. And so we are chasing quality. We are not chasing the lowest cost. That being said, there are savings to be had. There are ways we can partner. As everybody said today, many times you've heard the word partner. And that is a big theme of, I think, what we're talking about today. And we can work with you. We can work with the patients. We can work with the physician communities to attempt to drive down cost, but only in the service of quality. As we know, sometimes doing less has a better outcome. And whenever we can find that, we would pursue that. So with that, thank you very much. It's been my pleasure.
As a 16-year-long cancer survivor, I'm very happy to hear about your plans for your Miami Cancer Institute. Our next and final panel is on the role of brokers in the era of healthcare reform. So I'd like to call up the speakers who are going to be participating. Shannon Alfonso, President, Florida Region of Marsh and McLennan Agency. Ron Calhoun, National Healthcare Practice Leader, Aon Risk Solutions. Glenn Evelyn, Market Practice Leader and Florida Area Market President, Arthur J. Gallagher and Company. Terry Fuentes, Senior Vice President, Human Capital Practice, Willis. Brian McNulty, Southeast Regional Employee Benefits Practice Leader, USI Insurance Services, LLC. And a familiar face and voice, Rachel Sapoznik, Founder, President, and Chief Executive Officer, Sapoznik Insurance. Welcome, all of you.
Thank you.
And I know that I think Terry is perhaps going on maybe needing to take a flight or needing to leave soon, I'm told.
Yes, a flight.
Okay, so therefore, I'm gonna throw the first question at you. I want to make sure you get a chance to speak. As the way healthcare is sold is changing, how do you see your role as a broker evolving in the short term and longer term?
Well, I would say that, and for quite some time, and I can probably speak for most of us here who've been in this market for so many years, the role of the broker has really been a consultant. Our sales job pretty much ends the moment that we obtain the client. From that point forward, it's our role to make sure that we're educating them, that we're doing the appropriate data analytics, that we're guiding them into the right direction so that they can ultimately meet what their goals are. That there's no silver bullet. I think our role is going to just continue to have more and more emphasis in that area. Needless to say, healthcare reform has brought a tremendous amount of legal questions to the table. For those of us like myself who are supported by a very strong legal team, I thank them every day so I can focus on some of the other things. But the ultimate role will be a collaborative role with not only our partners in the health insurance industry, but I think and I hope more so with the providers in the community, because we do need to educate our employers as well as their employees about what is changing in healthcare. It is just something that the message needs to continue to occur. That's where we're seeing a lot of our focus shifting toward, in addition to the things that we've been doing in the past, which a lot of it is data and consultative and cost containment ideas.
Are you finding that it's becoming, that the focus was very much employer and large group, and now more on an individual basis? That they're trying to shift the responsibility more to individuals?
Absolutely.
Employers? Yeah.
And it almost has to be to a certain extent, because as some of my colleagues here mentioned, there's accountability that needs to take place at the individual level. And employers only have a certain amount of dollars they can realistically spend on healthcare. So the individual does need to take ownership. We do see a rise of consumer-driven health plans, HSA compatible. If you read some of the surveys of what the larger employers are doing, they're becoming more likely to be total replacement. I think transparency is an area that consumers truly need to be more aware of, but they need guidance. And there are multiple ways to provide that guidance, and that's part of our role, is how to get that access and the guidance. The guidance that they're getting from their physician is great, but a lot of times they go home and they completely forget half of what they've been told.
I would just add to that if you thought being in this business was easy before the Affordable Care Act, maybe we should talk after, because it wasn't easy before. And it got way more complicated for us, for our carrier partners, for our provider partners, for our clients, and for individuals. I speak to the seniors out in the market that don't even understand Medicare today. So just talk to one of those folks. They don't even understand what it means, how they get it, what their options are. And now we just added a whole bunch of other complexities around it. So our jobs are harder. They're definitely not getting easier. And we're shifting more to a consumer focus. If you step back and look at what we do working with employers, we help employers figure out what is it that they can do to bring a package to their employees that their employees value. In the past, they did it because they wanted to. Now they do it because they have to. How do we continue to carry that value in that program without losing that, because now we have some laws that we have to abide by? So we're spending a significant amount of time working with those employers to help them educate their employees about what their choices are, what the mandates are, and then going out in the market and shopping like a consumer for everything else you shop for. I think we're switching from the mentality of, I need to have the most expensive program that pays for everything. That just is not realistic. So our job is to help them understand what is the right amount of insurance to have. Then when I have the insurance, how do I use it, and what do I do to minimize my risk over time and keep my own costs down as an individual?
Glenn, I see you shaking your head.
Absolutely. From our perspective, our role has absolutely changed. We've become compliance experts, communication experts, technology, ben admin, workforce evaluation, human resources, wellness and health management. 10 years ago, it was about shopping a market and laying out a spreadsheet for employers to make an informed decision. Today, it's about understanding that workforce, understanding that there's 4 different generations in the workforce today. They think differently, they operate differently, they make different decisions, and their healthcare needs are different. How do you communicate to that population in a way where people can get it and they could get engaged in the process, stay healthy and productive? So our role has absolutely changed. I do think that what we're seeing is it's going to be much more difficult for the individual practitioner to practice our business. The resources that's taken to consult and to be a broker today are huge. You literally need a team of specialists in almost every single area to accommodate an employer about what's going on in the industry, stay compliant, and to engage their employees a little differently.
I would add to something else that he mentioned about the diverse population. It's true, you've got the generations of all the different alphabets, whatever they are. But at the end of the day, for those of us that are here all the time in South Florida, for the most part, where most of our clients are headquartered, because I know we have some visitors from other areas. The additional challenge that we've had, especially over the last 5 years, is dealing with not just the employee, but corporate executives that are completely unfamiliar with the healthcare system and the insurance system in the US. They're coming from single-payer environments, and they are absolutely clueless as to what their role as the employer is. And it's been a difficult thing for them to embrace. So that has added to the additional, cultural issues that we have today, and kind of just it's almost like trying to fit a round hole into a square peg. It's gonna take time.
Just another point, we are seeing a transformation in the business. It's not employer one-size-fit-all benefit levels. It is customizing those total reward benefit packages to the individual consumer's needs and the needs of their family. And we are getting involved much more into individual insurance as well. Employers are now looking at, the public exchange, for instance, as an opportunity to offload their COBRA participants, which are higher costs that stay on their plan, that affect their claims experience, and their credibility going forward. We're looking at employers looking at excluding spouses for coverage. And if you exclude a spouse, they can go to the public exchange and potentially get a subsidy. We're looking at small businesses looking at the fact that they don't want to be in insurance anymore. They can basically say, I'm out, drive their membership to the public exchange, maybe get a subsidy. It could be a better situation for the employee and for the employer. So, when you look at your second or third highest expense next to payroll and occupancy costs, it needs to be managed differently. And I think companies now are getting that.
If I could just chime in here. I think that the good employers have always provided health insurance. And really the idea of insurance was really about employee retention. And we never lost that. So the fact, I'm not seeing my clients say, I'm not going to provide insurance anymore, because we as the brokers have to remind our clients, hey, you've always provided insurance. You are a responsible employer, and what was important to you was having quality employees. And one of the things that quality employees look for is a good benefit package from their employer. And I think our role as the broker is to bring sanity back to this whole idea of healthcare reform. Because with the idea of retention of employees, it is so costly to replace your employee. Everybody knows how costly that is. And one of the things that good employees will look for is healthcare. The other role that we have taken on as insurance brokers is we need to change behavior. And the idea of everything being covered, right, it is a misnomer that everything needs to be covered. But it is also very important to understand that the employees need to be engaged and understand how they can be part of the solution by being compliant with their own health. And we are here now to bring programs to employers to educate them as to how they can have their employees really understand how they can reduce healthcare costs. So healthcare reform may have been brought the idea of health insurance to the attention of the public, but the good employers, the employers that understand growth, will always provide health insurance. It is our job to try to control those costs in a responsible manner. And I see the role of the broker expanding. We need to have good brokers in this market that understand how to make a difference for their employer and for the employees.
I'd like to get Mr. Calhoun and Mr. McNulty to weigh in on a different question. Can you talk to us about what you're doing to ensure that your customers are offered a stable provider network and able to maintain the providers and services that they want?
We're arguing on who's going first.
Those are the
Answer that for
quiet
Humana.
guys over there.
Answer that for Humana.
Yeah, Humana.
Oh,
Teasing.
Start there.
I'm kind of out of that fight, actually. I'm a bit of an oddball on the panel in that I represent healthcare providers across the country, deal with emerging risk related to reform. So I have a little bit different take here, but I want to answer that question in a little bit different way. And it kind of ties back to this gentleman's question earlier in the morning about Alina versus Fairview. We have approximately 626 accountable care organizations across the country right now. And somebody made the comment earlier, you've seen one, absolutely. But what we're seeing is a trend. We're projecting a 10-year projection of revenue of the healthcare provider community across the country. And they really have 4 pathways. They can either pursue, and it depends on the amount of their, and let me caveat what I'm saying by saying that nothing that I'm going to say has anything directly to do with Baptists. So I'm going to get that disclaimer out there right now. I'm just talking about in general across the country. We see basically 4 pathways. A population manager, and that's the entity that has the appropriate ambulatory assets, primary care assets, in some cases post-acute assets, to be able to take a global bundle that was discussed this morning. For those players that don't have those appropriate assets, they're going down the path of a clinical destination, rallying around a specific clinical bundle, for example, whether it's cardiac, orthopedic, et cetera. And there are a small group that have the resources to be both. And there are, Ralph alluded to this group earlier this morning, that there is a group that is, quite frankly, is hanging on to fee-for-service as long as possible until I've had chief strategy officers actually articulate to me, we'll change when we see the track run out and we absolutely have to change, and it'll be way too late at that point. So I think there's going to be a lot of disruption in that category. There'll be, we have an oversupply of acute care beds in this country. There'll be about 6 to 7, there's some estimations as high as 800 facilities that will close, particularly those in rural environments. We're seeing a lot of alternative care strategies emerge in rural America, particularly in the South. The dynamics are a little bit different in the West than they are in the South. So to answer your question, what we will see emerge, and I'll actually, let me make one more comment. We'll go off on a tangent here. Large employers, I collaborate a lot with Aon Hewitt, our employee benefit consulting half of the house. We have a relationship with 70% roughly of the Fortune 500. So they basically have 4 pathways, 4 strategic pathways. They can exit completely and pay to fine. They can continue to manage trend the way they've been managing it historically and over several years at double digit. That's actually the smallest strategy, the lowest percentage. They can subsidize migration into the exchanges, or there's a 4th category called house money, what we're calling house money, house rules. We're going to keep our employee, to your point, we're going to keep our ERISA self-funded employee benefit plan. It's our money. You're going to play by our rules. 19% of the Fortune 500 actually deploy penalties now. Another 38% are considering doing so. So in that population, roughly 63% of the Fortune 1000 are migrating in that house money, house rules direction. So what we're seeing right now is a proliferation of direct contracting strategies. Some in collaboration with the payers, others, quite frankly, intermediating the payers. That varies by market dramatically. And one thing that we are owning is educating our large employer clients on the employer side on what these direct contracting strategies, either in collaboration with the payers or directly, look like, what the consequences are. We have some large Fortune 50 companies that have reached the saturation point. They've said enough is enough. We have 30,000 employees in this particular market in the Midwest. This is a real example. We are going to give an RFP for all of the integrated delivery systems in that market. We want negative 1% trend over 5 years. 5 years from now, we want negative 5% trend over where we are right now. Take it or leave it. There are systems in that market that don't have the wherewithal, should never enter into that type of arrangement, but are scared to death not to. So we're seeing a lot of that across the country. So I think it's incumbent upon us to guide our large employers in what's feasible in certain markets. There's clearly a trend going away from large national solutions for the national employers and picking specific strategies for specific regions. There's a large home improvement retailer that everybody knows. They do all of their pelvic organ prolapse procedures at Geisinger Clinic. They actually warrant that procedure for 100 days. They provide through their self-insured captive a warranty for that particular procedure. So we're seeing a lot of variations on that theme.
That's interesting. Do you want to?
The way we handle that today for our clients to make sure they have access to a stable network is going to change dramatically going forward. But the way we do it today is, we'll do a geo-access analysis. We'll look at their census, make sure they're within their zip codes. We have adequate coverage, especially if there's an employer that has multi-state locations, to make sure they have access to providers within their areas. As we see the evolving ACO market and trend, everything is going to change and shift in those directions. And as we've seen with certain carrier markets, as one carrier has been mentioned here today more than once, those can change overnight. So it can be difficult to access a stable provider network going forward. There's consolidation. There will be more consolidation going forward. There's been a lot of consolidation on the carrier side. Don't know how much more of that is still left, because we're down to a pretty finite number. But it'll change going forward. There'll be less access. As Ron mentioned, in the rural areas, there's going to be some that go away completely. And as it was mentioned earlier, there'll be a lot more outpatient facilities hopefully emerging in some of those areas. So that's what's coming down the road.
Do you think, are a lot of the decisions that are being made on the consumer level based on provider networks, or more based on price? What is the driving force?
So you got to understand what's going on in Florida. We're a hospitality state. We have some of the highest healthcare costs, some of the lowest contribution from employers. Most employers, especially here in South Florida, they don't contribute anything for dependent costs. It's a challenge. And today, employers are making decisions based on the breadth of the network, but they're also making decisions based on price. And what we're seeing is we are seeing limited networks being more of a viable alternative for employers who are adding dozens of employees or hundreds of employees because of the ACA. It's a matter of affordability. If you can't afford to bring in, by lowering your hours, increasing your eligibility population, introducing a whole new population to the employer health plan, that's caused a lot of stress. What's going to happen in the future is we believe that employers are going to be able to choose through either public exchanges or private exchanges, multiple carriers with multiple different networks, and then it will fall back onto the consumer what network best meets their needs of their family, their medical needs, as well as their financial abilities.
But the problem has been that the consumer has not been privy, full transparency into the cost.
Right.
They may know what their premium is out of their paycheck, but when they're actually utilizing the service, in this market in particular, we're still very much in a copay-driven market. We've slowly started to migrate into deductibles and coinsurance, which is forcing more of that question on the front end about what is it going to cost for this service. So it's opening the eyes of the consumer to say, well, wait a minute, if I go to one facility versus a different facility, you mean it's different? And absolutely it is, but that was something they did not know in the past. And so where they would be, I guess, negative about a limited network, it was because of access. I say you give them access, you give them choice, you let them make the decision based on the cost and the quality measures that they should be able to look at.
Well, I find that really hard because the average consumer, they don't have the education to really understand what it takes to make a decision on healthcare. It is very difficult. We are in the hospitality industry, and many of our clients are housekeeping, wait staff, foreigners from Haiti, Colombia, who come to this country and now are being asked to make a decision on healthcare. It is beyond their capabilities. Not because they're not intelligent enough to make the decision, it's because they are not used to our system. And the employer has a very important role in this. And if we remove the employer and the broker from the decision-making ability for these people, the decisions that they make are going to be financial decisions based on their paycheck without really understanding the dynamics of what happens when there's a claim. That's where the real dollars are. And we're throwing around deductibles of $6,300, $2,500, $12,000 family deductibles. For those of us sitting here, we can afford it. We're not going to lose our house over that. Well, they are. They're going to lose their car. They're going to lose their house. They don't have that kind of money. And to me, what healthcare reform has done to those people, honestly, has hurt them more than anything, because they did have better plans before than today. Some people, yes, did not have plans, but many people had very good plans, and those plans have been destroyed because of this. And that is something that we have to think about when we try to push that decision back to those people that don't have the ability to make those decisions properly.
It's a hard balance because it's sustainability. I mean, and one thing we haven't talked about much here, which might be something to bring into the next summit, is, pharmaceutical. We've got specialty drugs that are on the double-digit rise. You've got Sovaldi out there, and it's cousin generic drugs, which are $1,000 a pill or more. And as much as, and I agree with what Rachel's saying about the cultural issues that we have, but we can't not try to give them everything possible to arm them. Half, if not more, of these folks that we believe can't understand the healthcare system are still walking around with smartphones and doing all this other stuff, but it's gonna take time. It is not overnight. And it requires the physician to be on the same page with the employer, to be on the same page with the carrier. And I know I might be talking, utopia here, but I truly hope, and I hope I see it in my lifetime, that we get to that point.
Just a quick question. I think just given, and I'm kind of tainted by the filter of being in several different markets across the country. There's a wide, we're a very diverse country, and there's a wide variety of capability of being able to understand, what you're buying. And I think that Cast Light, I think Healthcare Blue Book are terrific platforms to bring a level of cost transparency to the table. But there is a wide variety. I want to also comment on the point that you just made about the high deductibles. I do think that one of the unintended consequences of not only the ACA, but this proliferation of private exchanges as a result, the ACA was really the tipping point, is we're really shifting, and particularly in states that are not accepting the Medicaid expansion, we are shifting significant amounts of credit risk to the provider in these growing, the ranks of the bronze plans. It was a great illustration, $50,000 annual household income in and out of pocket. I think the total out of pocket was 11 or 12,000. That's a significant amount of credit risk. A lot of providers across the country are actually innocently extending payment plans and whatnot to their patients, and you're now in the consumer credit space. In a violation of about 12 different statutes as it relates to that. So it's very, very complex.
Brian, did you want to say something?
Yes, to Ralph's chart that was up earlier, which I think really identifies, we need to shrink the pie overall, and 5% of the population consumes 50% of the cost, 10%, 65%. So if you're a large enough employer today, you can get that data and figure out pretty easily who those people are. The trick is to then figure out who it's going to be next year and the year after that and the year after that. Who's your at-risk population that's not at that level, who's innocently working their way up to that top 5%, and we don't want them to get there. So if you can identify those people, who are the diabetics, who are the people with high blood pressure, congestive heart failure, who are not treating their illness, who are not taking their meds, they're at a higher risk, and they're moving in that direction. So if you can identify them and get them into an active disease management program, where you're engaging them in their treatment program, you reduce their risks, you hopefully start to shrink that pie.
Since Rachel is on the panel, somebody from the audience is going to have to take her place at that microphone and ask a question before we have to adjourn for the day here. Thank you, Wayne.
There we go.
Payback time.
Payback.
Two things. One, we've done a lot with managing the employee population and have a lot of programs and things talking about identifying certain segments of the population. As Ralph said and everybody said, it's a small percentage that consume the vast amount of the spend for us. But some of the people we have here that would be perhaps helpful to you or some of your clients Dr. Tran, of course, and of course you all know Dr. Agustin, but also our HR director, Adrienne McCoy's there. Raise your hand, Adrienne, and Maggie Marshall also. So we have some expertise in the room who would be happy to be available to consult with anybody that you would point them to. My question is, how important do you see the physician panel network to the decision-making process of companies or individuals when they decide which plan to choose these days?
Very important. Very important. The first thing that typical decision makers are looking at is who's the doctors, who are the hospitals. It is a very important factor. And again, just to as you know, because of the Humana situation, I've got clients that already called me and said, okay, we have to make a move because our lead hospital is no longer in the plan. So the doctors are significantly important. The hospitals are very important. And I think it is imperative that we keep the lines of communication open with the doctors and hospitals and the insurance companies. What scares me, and probably scares everybody sitting here, is when the insurance companies narrows down their network and we don't really know who they eliminated, and we're going around with these skinny networks, and people think that they're walking around with an Aetna card or a Blue Cross card or a Cigna card or whatever, and they think they have a full panel, and they don't. It's very risky, particularly if you're walking in there in an emergency situation and that doctor's not in network and you're not in an HMO, you are not protected. That out-of-pocket cost is astronomical. So to me, the equation is to really work together, and the doctor network is absolutely crucial to the decision-making process.
I would also say it's crucial to the ability to keep costs down. You know, we found and learned that, you know, you get a population to use higher performance doctors. They may not be the least amount of cost from a discount standpoint, but on a per episodic basis, they're going to be a lower cost provider over time. Better care, better quality equals lower cost. So for us, part of all of our practice is trying to educate those employers how to identify those high performance groups and really improve steerage to those physicians to get better quality care, which ultimately produces better cost.
You know, I'm so glad that we're talking about this, because I think it's a topic. Healthcare reform is not necessarily a popular topic, but it's here and it's important. And as someone who is now self-employed and will soon be in the marketplace shopping for insurance, I've learned a lot today. I hope that you have all learned a lot, and I thank you so much for being here and for sharing your perspective and insights, and hopefully we'll do this again in the future. You're pointing at somebody.
One more question.
Okay.
Chris Olson, I know a bunch of you up there, but because I've been doing this for a long time, how are you all handling right now your clients, as we call them virgin clients, that are just coming into the market now? They're the valet parking companies, they're your hospitality companies, they're your restaurant companies that have 6,000, 7,000 employees, sometimes even 500 or 600 right here in our local community. And we have no perspective on who's going to enroll. Sometimes we do employee surveys to see who's likely to enroll, and we get participation at 5%, 6%, 7%. And we're going to the carriers, and we know that they're going to hike that up. And these are companies that have to comply coming into the system, and I'm finding it very challenging to go out and provide them a rate knowing that that could go up by 50, 60%. And I just wanted to see what your perspective was on how you're handling those new clients that all have to be compliant as of January 1st.
I mean, basically what we're doing is, and I understand what you're saying, Chris, it is a challenge, but I think the education has to come from us to the employer. Employers cannot expect their employees to participate unless they're going to make a significant contribution. We know that the penalty is $2,000, could be $3,000. So we have to set up the structure so that there is an affordable plan and work with the carrier. And I think it is a challenge. But working with a carrier and trying to develop a plan design that's compliant and affordable is possible. It's going to take a lot of boots on the ground. This is a boots on the ground time. This is not a time for emailing, this is your plan. We need to be there, and what we're doing as our agency is we have boots on the ground, we have agents going to our clients, potential new clients, educating those employees about healthcare reform, educating them about how much the penalty is this year, how much the real payroll deduction is after the pre-tax. So if you can sit down with an employee, explain to them that your payroll deduction is going to be pre-tax, you're going to save taxes there, you're going to save on not getting the penalty, your employer is going to contribute, you will see your participation incredibly increase, Chris, but it takes boots on the ground. That's what we need right now.
So I have employers that are telling me to push back on that because they don't want that engagement whereby you're saying, hey, your penalty is $95 or your payroll deduction is $30 a week, which is $120 a month, and you make minimum wage. And we're going to deduct $1,500 or $1,600 out of your paycheck, or you go bare with it. And it's hard to make that case.
Well, the penalty for 2015 is not $95. It's a higher penalty, I believe it's 2%, and it's of gross income, household gross income, so it's not $95. So you have to look at what the real number is, and they need to understand that because that is a real number to them.
Well, and I think back to the point I tried to make earlier before, a lot of employers are faced with the fact that they have to cover populations that they never covered before. They have to budget it. They have to figure out how to fund it, which is a big issue. So before it even gets to the consumer making an informed decision and shopping well, it's going to come down to the employers, and employers are looking for anything they can do to lower their costs, including limited network plans. So it's a bigger draw, and it will be a bigger draw for employers in those types of situations.
It's a great question, and then you've got to work very closely with your carrier partners here at the table, which would have been a great question for that panel, but yeah, I'm sure you did. But medical questionnaires can sometimes help with that, Chris, and we've had a couple of those that have worked out that way, but it's a real challenge, no question.
I think we have one more comment, and we have
Just
to
a very quick,
close.
I just want to make a quick comment about narrow networks, because it's prevalent in the hospitality space. So Marriott just developed a narrow network in Chicago, for example. And what we're seeing is that in each market, there's a tipping point where the providers, now they're using Comparian or the Delta Group to do the quality measure work. But at the end of the day, there is a number, there's a tipping point in every market where providers reach a point where the guaranteed increased volume is just not worth the deeper discount. And that number varies by market. In Chicago, it's about 100,000. So that is kind of, by definition, a transitory strategy. And I don't see that lasting long term.
Okay, thank you very much, panelists. Thank you. Let's give him a hand. I'm the last word, so if you give me one more minute, I'll try to close it. My original intent was to summarize what we heard today, but it'll be an impossible task to do in 2 minutes, so I'm not going to even try. I'm only going to say that Baptist Health is extremely proud to have all of you here to participate in a very engaging conversation about a very important topic. I think you heard about the qualities, capabilities, innovation that Baptist Health offers. And I hope you keep that in mind throughout your dealings with your customers. I also remind everybody, in case you need to, that the Affordable Care Act is a very complicated system, complicated law, and that there's a lot of work that needs to be done in order for it to be successful. So thank you again for your participation. Thank you, Diane, for having been the moderator. Thank you to all the staff that were behind the scenes to make this possible. And again, thank you for being here on a very rainy day. So with that, bye.